everyone. I hope I'm clearly visible and audible. Let me confirm if I'm clearly visible and audible. I will start the lecture ahead. Give me a minute to confirm it. You can give me a thumbs up in the chat box if you can clearly see me and hear me. If visibility audit, okay, I hope it is working. Yes, I hope it is working. So I welcome you all for today's session. A very good morning to all of you. I am Dr. Priyanka Sachdev here, and today I am here to continue my series of pharmacology. In pharmacology, we have started general pharmacology. In general pharmacology, we have started the first chapter, that is pharmacokinetics, in the last lecture, a day before yesterday. And today I am going to continue pharmacokinetics first and finish it. So, just a second. We have started pharmacokinetics. I have already taught you that in pharmacology, we are having two branches, that is pharmacokinetics and pharmacodynamics. Pharmacokinetics and pharmacodynamics. Before starting it, you should understand the difference between them. I have already taught you that in pharmacodynamics, D for D, what the drug does to the body is known as dynamics. So if I'm having any disease, I'm taking a drug for it. The drug is curing the disease, the treating the disease. So here comes the mechanism of action of the drug. So mechanism of action of the drug, the main drug which is treating the disease, is coming under pharmacodynamics, which I am going to teach you tomorrow, right? In pharmacokinetics, what the body does to the drug, that portion comes. So if I'm having any disease, the body first has to absorb the drug by whatever route I am taking. I can take it by oral route, I can take it intramuscular, subcutaneous, IV, topical. There are various routes, you know. So from the site of administration till blood, the drug should reach the blood. It is absorption. We have completed absorption in the last lecture. I guess you all were there, right? After absorption, the second topic is distribution, which I will complete today. So from the site of absorption, the drug should reach to the site of action. From blood, it should reach the site of action. That is distribution. After going to site of action, it will show its mechanism of action. Now we want to excrete the drug. But drug cannot be directly excreted, right? Before excreting, you should convert non-polar drug to polar drug, insoluble drug to soluble drug. Then only it will be excreted in urine. Because urine is liquid, it is water. So only polar substances can dissolve in urine. So you have to convert non-polar drug into polar drug first. That part is known as biotransformation or metabolism. So pharmacokinetics basically have four parts: absorption, distribution, metabolism or biotransformation, one and the same thing, and excretion. We have understood these basics, I guess. We have already understood these basics. So I have started with pharmacokinetics. You can see the very beautiful diagram. Let me see if I can see your chat. Just a second. Give me a thumbs up. Anyone from the audience, please give me a thumbs up in the comment box. So it will be confirmed that I can see your chat. Anyone? Okay. So listen, this is a beautiful diagram. You can see this is the drug. The drug is taken by the oral route. By oral route, the drug is reaching the esophagus, the drug is reaching the stomach, and the drug is reaching the intestine. From the stomach and intestine, the drug is absorbed. Now, in the last lecture, I taught you for absorption, same medium is required. That is, acidic drugs are absorbed from acidic medium, that is stomach. And basic drugs are absorbed from basic medium, that is intestine. So, acidic drugs absorbed from acidic medium, basic drugs absorbed from basic medium. We have understood this concept completely in the last lecture. Ultimately, the drug is reaching in the blood. Now, this process is known as absorption. Absorption ka definition we have seen from the site of administration to the blood, to the circulation. From the site of administration to circulation, the movement of the drug from site of administration to blood to circulation is known as absorption. Ultimately, absorption is over. We have seen all the factors responsible for absorption. There were, I guess, 9 factors. The most important factor was the pH. We have covered the pH completely. I hope you students were there and you have watched the recordings and you don't have any doubt in that. Now, the drug is already in the blood. Now, it has to go to its site of action. If I am having headache, I am taking a drug for it. After going in my blood, the drug should go to the brain parenchyma from the blood and should act on it. If I am having diarrhea, it should go to the intestine. If I am having any disease, the drug should go to that particular organ. That is known as site of action, right? And after that, after showing mechanism of action there, the drug will enter there, show its mechanism of action there. The disease will be treated or not treated, whatever. Now, the drug part is over in the body. The drug part is, now you want to excrete the drug. So, drug will again come in the blood. After coming in the blood, Now drug want to go to the kidney for excretion, but kidney will say, no, I will not excrete you because you are non-polar. First get converted into polar, then come back to me. So drug will go to the liver. The liver will convert non-polar drug to polar drug. This is known as metabolism. This step is known as metabolism or biotransformation, in which you convert a non-polar, that is insoluble, water insoluble drug, to polar, that is water soluble. Now after getting converted, the polar drug, now it is finally polar. So polar drug finally come in the blood, and from blood it will go to the kidney, and kidney will excrete it out in the form of the urine. So this is the whole mechanism, and last step is known as excretion. So you know it well. There are 4 portions. You can see it well. Just a second. Okay. So there are 4 portions. So it is absorption. It is the second one is distribution, then metabolism and excretion. So I have already covered the absorption. Let me start with distribution. You have to give me a minute to jump on the slide where I left in the last lecture. So give me a minute so that I can directly jump there. Okay, so we will start from distribution, right? Just a second. Yeah. So here I am. So we will start with distribution. Okay. So absorption is over. Let me start with distribution now. So you can see here, okay. So here the drug I am taking by oral route. Just suppose you see this is the drug. The drug is going in esophagus. It is going in stomach and intestine. It is absorbed from the stomach or intestine depending whether it is acidic or basic. Now listen, once the drug come in blood, some proportion of it bound with the protein. Which protein? The blue is the protein. Red is the drug and blue is the protein. Just suppose I am taking total 100 gram of drug. So out of 100, maybe 90 is free and 10 is bound to the protein, or maybe 10 is free, 90 bound to the protein. It differs from drug to drug. It differs from drug to drug. So please, in the blood, the drug have 2 forms. The free form, which is not bound to the protein, and the bound form, which is bound to the protein. Everyone give me a thumbs up. Now you have to understand the detail of this, please. So this is the protein. Now you will ask, ma'am, which protein? Name the protein. If it is acidic drug, it will bound to albumin. The name of the protein is albumin. And if it is a basic drug, the name of the protein is alpha 1 glycoprotein. So there are 2 proteins which bound with the drug, depending whether the drug is acidic or the drug is basic. We have seen the drugs are of 2 types, acidic drug and basic drug. So acidic drugs bound to albumin, basic drugs bound to alpha 1 glycoprotein. So ultimately some proportion of the drug is bound. So this is known as bound form and this is known as free form. Everyone give me a thumbs up. There is another name given to the bound form. It is plasma protein binding. It is known as PPB, plasma protein binding of the drug. So plasma protein, PPB, it is known as PPB. Plasma protein binding of the drug is visible here. Are you sure? Have you got the concept? Should I go ahead? Give me a thumbs up. Should I go ahead? So this is the 2 forms of the drug. Now listen the concept. Now it is the free drug which will go to the site of action and show mechanism of action. Bound drug will not go to the site of action. It is the free drug which will go to the liver and convert from non-polar to polar form. Bound drug will not go to the liver for metabolism. And it is the free drug which will go in the kidney for excretion. It will be excreted in the urine. Bound drug will not go to the kidney for excretion. So free drug is the active drug. It will go to site of action, show mechanism of action. It will go to the liver and do the metabolism. It will go to the kidney and get excreted. So it is the active form of the drug. So you will ask, ma'am, why we have bound form? Bound form is the reservoir. It is acting like a reservoir. It is acting like a reservoir. So when, just imagine 90 free drug and 10 bound drug is there. So this 90 will go here, here and here. So its proportion will fall. It will go to the site of action, it will go to the liver, it will be excreted. So gradually from 90 it will become 80, 70, 60, 50. So when its proportion will fall, bound will give the backup. Bound will get converted into free and keep the free concentration always 90, it is constant till both of them will become 0. So gradually when free will fall because of entry in these 3 organs, because of entry at the site of action, entry in the liver and entry in the kidney and excreted out of the body in the form of the urine. So free will fall. So when free will fall, bound will convert into free and bound will also fall. So there is a parallel decline in both of them. And ultimately at one point, both will be 0 in the body because both will be excreted. Not both, actually free will be excreted. But all the bond will, at one point, all the bond will get converted into free to give the backup. So active form is free and reservoir or backup form is the bound. This is a big concept I taught you. This is a very big concept I taught you. So that is known as drug distribution. That is the delivery of the drug to the tissues. I am talking about three tissues. So it is that the active drug, the free drug is going to three parts. That is site of action, the organ of site of action, the liver and the kidney. Liver for metabolism and kidney for excretion, right? So these three tissue mein which drug will enter? It is the free drug which is entering. And what about bound drug? Bound drug is giving the backup to the free drug. So when free will fall, bond will give conversion to the free, and ultimately both of them will excreted out of the body, and at one point both of them will be completely excreted out of the body, and both of them will become zero. So that is a big concept I have given you. Please everyone first give me a thumbs up. Let me see if you got this concept so I can move to the next concept. I can move to the next concept. It is a big concept which I am going to tell you next. First, everyone give me a thumbs up. Everyone first give me a thumbs up. Yes. So Pranali, Shivang, Bablu, give me a thumbs up. Can you see me? Can you see me? Give me a thumbs up. You got the concept? Should I proceed ahead? Okay. Okay, Princess Shivang Kumar. Very good. I got it. So listen. Same thing is written in front of you. So once the drug get access to the blood, number one, right? Now it's variable proportion. It is not fixed ki how much. So either 90 will be free or 10 is bound, or 10 is free, 90 will bound, or both will be 50-50. I don't know. It differs from drug to drug. So variable proportion will be bound to the plasma protein. Plasma protein are of two type, albumin and glycoprotein, alpha-1 glycoprotein. Acidic drugs bind with albumin, basic drugs bind with alpha-1 glycoprotein. Both are plasma protein, right? Now this form is known as bound form. The another name given to the bound form is plasma protein binding. The another name given to the bound form is plasma protein binding. Give me a thumbs up if you got it. Yes, right? So now it is the free form which is distributed. It will go to the three organs, that is site of action, liver and kidney, not the bound form. So gradually its concentration will fall. The free drug will fall. Gradually its concentration will fall. But there is an equilibrium between the free and the bound. So the backup is given by the bound. So there is a parallel decline in free as well as bound. Have you got it? Have you got it? And ultimately both of them will be excreted. Now the next concept which I told you in the last lecture also, that is apparent volume of distribution. You can understand it like this, it is an experiment to prove distribution. So distribution is basically free drug is entering here, here and here. So the concentration of free drug is less in the blood. In the blood which is remaining? Only bound is remaining. Bound is present in the blood. Free will never be present in the blood. All the free will enter either here or here or here. Whatever free is this. Whether it is 90, 10, 20, whatever free is present, it will go here, here, here. So in the blood, basically you have bound. Blood, B for bound, B for blood. In the blood we have bound. In the blood we don't have free. Once the free is there, as soon as free is there, free will enter in the three organs at the site of action, in the liver and in the kidney, right? So there is no free in the blood. You got this concept? It is a big concept to understand volume of distribution. Very few students can understand volume of distribution, right? So we will do an experiment. We will do an experiment to prove the volume of distribution. Let me draw a diagram for you. Give me a minute. Okay. We will take two diagrams. Now it is a big concept I am telling you, huh? So we will make two diagrams. So in both the diagrams, listen, this is a blood vessel. This is a blood vessel of the experimental animal. I am taking two experimental animal or two human subjects, whatever. This is the blood vessel. Both of them, I am giving an injection. I am giving a IV injection of the drug. It is 1000 milligram of the drug I am giving IV to both of them. 1000 milligram of the drug I am giving IV to both of them. Everyone give me a thumbs up, everyone. Now in the first, what I am considering, it is a single unit. There is no organ. So I am assuming all the 1000 is going in the blood. All the 1000 is going in the blood and getting distributed throughout the blood. So all the 1000 is reaching in the blood and getting distributed throughout the blood. So after that, I am taking a blood sample out. I am taking a blood sample out. Let it get distributed in the first 5-10 minutes. Then take a blood sample and see the plasma concentration of the drug. How much drug is present in the blood? You have given 1000. You have given 1000. Now how much is present in the blood? Plasma concentration means blood concentration of the drug. So you found out that blood concentration is only 50 milligram per liter. 50 milligram per liter. This is the concentration. What do you mean by that? 1 liter contains 50 milligram. So 50 milligram ke liye you require 1 liter of blood. That is the meaning of this. Yes or no? But you have injected 1000 milligram, not 50. You have injected 1000. So for 1000 milligram, how many liter of blood you require? You tell me. For 50, you require 1. For every 50, you require 1. So for 1000 you will require how much? So it will be 1000 by 50, that is 20 liter of blood. 20 liter. So what is the answer here? 20 liter. So 20 liter is the volume of distribution. Now you will say, ma'am, humans don't have 20 liter of blood. We have maximum 5 liter of blood. So this is a human experiment. In human experiment, we have only 5 liter of blood. How answer can be 20? So, but this will happen really. This will happen actually. This will happen actually. So you will say, ma'am, how it is possible? That's why I am saying it is not real volume of distribution. This is apparent volume of distribution. It is pseudo. It is apparent. I am assuming why this is happening. You will say, ma'am, why this is happening? We have only 5 liter, but your answer is coming 20 liter, and you are saying this is a real experiment. It will happen. If I perform it, it will happen. So how it is possible? Okay, my answer to your question is distribution. Here I have considered no distribution, right? Well, I am considering whatever drug I am giving. See, all 1000 is present in blood only. I'm assuming all 1000 is present in blood only. So it is not the case. If I'm giving the 1000, just a second, let me think यहाँ पे 5 आंसर लाने के लिए कितना चाहिए मुझे? यहाँ पे 5 कब आएगा? When 20 होगा, है ना? 20, yes. If instead of 50 it is 20, then the answer, if instead of 50, when the answer will be 5 liter, what is the concentration of plasma? So let me see, 1000 upon 20 is 50. Okay, 1000 upon 200. 1000 upon 200 is 5. Yes, 200. So, okay. Listen. So, okay. So, here is the 1000 milligram you are giving. But out of the 1000 milligram, out of the 1000, only 200 is remaining. Rest of the 800 is entering in various organs. You can see here it is entering, here it is entering, here it is entering. It is entering everywhere. It is entering everywhere. Have you got it? It is entering everywhere. Give me a thumbs up. Everyone give me a thumbs up. Everyone give me a thumbs up if you got it. 50. Okay, just a second. Okay, 750. Out of 1000, just suppose 750 is entering in the 3 organs. What are the 3 organs you say? It is site of action, it is liver, and it is kidney. So it is entering. So only 250 is remaining here. Actually only 250. So I have given 1000, but only 250 is the bound form. Rest of the 750 was the free form. Right? Actually this is happening after going inside. So when I took a blood sample out, so it is 50 milligram per liter. Now apply it again. 50 milligram per liter. So 50 milligram of the drug requires 1 liter of blood. But actually we have 250 milligram of the drug, not 1000. Initially I was considering 1000 because I was considering no distribution. But actually it is not 1000. Out of the 1000, 750 have already entered in the tissues because of distribution, and 250 is remaining. So for 250, how much will it will be? So 250 upon 50, it will be 5. It will be 5. That looks nice. Yeah, we have 5 liter of blood. So that is the thing. So this experiment is proving that distribution actually happens. So what is apparent volume of distribution? In apparent volume of distribution, I am assuming the human body as one homogeneous compartment. I am not assuming the organs. I am not assuming any organ. So I am assuming whatever drug I am giving, it is remaining in the blood only. It is going nowhere. I am assuming that. I am assuming. It is not reality. I am assuming that. Then in that scenario, whatever blood volume is coming, that is my apparent volume of distribution. Give me a thumbs up. And what is the formula of apparent volume of distribution? You tell me. It is 1000 by 50. What is 1000? 1000 is the IV dose which is given. And what is 50? 50 is the plasma concentration. So IV dose upon plasma concentration is the formula of apparent volume of distribution. When I consider the body as a homogeneous one single compartment, I am assuming there are no organs. That is the thing. I tried hard. Everyone give me a thumbs up. So apparent volume of distribution. Now very few students understood this concept, but I tried hard to explain you. So it is the volume of the plasma that will accommodate all the drug which you are giving. You are giving 1000 milligram now. So it will accommodate all the drug, that volume of the blood or that volume of the plasma, if we presume the body as a single homogeneous compartment. I am assuming no organ. I am assuming single homogeneous blood compartment only. So it will get distributed uniformly through the blood. So the answer will be 20, but it is not reality. So that is known as apparent volume of distribution. And what is the formula? It is dose given IV. Dose given IV, that is 1000 upon plasma concentration, that is 50. So 1000 by 50 will be 20. हमारा answer था in our experiment. So the formula of volume of distribution is dose given IV upon plasma concentration. Please write all the formulas at one place So make a notebook of pharmacology formulas. I will tell you more than 20 formulas today only, and we will solve numericals on based on all those formula by combination. So please write all the formulas together. That is my advice to you. Just a second. So let me move ahead. Have you got it? Let me move ahead. So what is the implication of calculating volume of distribution? Why we are calculating volume of distribution? Listen now, listen. See the same. Now you say, what is the formula of volume of distribution? You tell me. What is the formula? Volume of distribution is dose given IV upon plasma concentration. Plasma concentration of what? Plasma concentration of the drug. So plasma concentration is the free or the bound? Which one remain in the plasma? In the plasma it is the bound, it is not the free. So actually it is the plasma concentration of the bound form. Give me a thumbs up. Now you tell me, this is the formula. This is the formula. So can you see volume of distribution is inversely proportional to bound form, plasma concentration of the bound form. So more is the bound form, less is the plasma, less is the volume of distribution, and less is the bound form, more is the volume of distribution. And bound form is inversely proportional to free. If free is 90, bound is 10. If free is 10, bound is 90. You can see these both are inversely proportional. So you can say volume of distribution is directly proportional to the free form. Directly proportional to the free form, and volume of distribution is inversely proportional to the bound form, because bound form, have you got it? The formula of volume of distribution, I mean to say, it is dose given IV. Understand, huh? Dose given IV upon bound form. It is the plasma concentration of bound form. Bound form. So you can see in this formula, volume of distribution is inversely proportional to bound. It is inversely proportional, and bound is inversely proportional to free. So ulte ka ulta sulta. So bound is inversely proportional to free. So volume of distribution will be directly proportional to free. Give me a thumbs up. So the drugs which have more free form and less bound form will have high volume of distribution. If you want high volume of distribution, there should be high free form. And if you have low volume of distribution, you have low free form. It is directly. Everyone give me a thumbs up. Everyone. So let me assume two drugs in front of you. This is drug A. This is drug B. So both of them have free form also and bound form also. Let me write the values. So this is the drug A. Here free form is 10 and bound form is 90. The drug B, free form is 90 and bound form is 10. Give me a thumbs up. Give me a thumbs up. There are two drugs in front of you, right? Now different drugs have different free and bound form, variable proportion. So there are two drugs. Which of the two drugs, A and B, my question to you, which of the two drugs, A and B, will have high volume of distribution? Volume of distribution, the formulas are in front of you. The formulas are in front of you. Everyone apply the formulas and tell me which one have high volume, which drug have high volume of distribution, and which drug have low volume of distribution. So आप answer the first question. A and B में से high volume of distribution किसका होगा? It's very easy ना. Volume of distribution is directly proportional to the free form. See the free form. Here it is 10, here it is 90, here it is 90. So drug B will have high volume of distribution. Yes, very good. Kuldeep, Abhirami, very good, very good, very good. Pranali, yes. So it is drug B, and low volume of distribution, it will be drug A. You got the concept? You got the concept? Now listen the next concept here. Listen the next concept. Drug B will have more volume of distribution, means it will remain in the blood. Basically, it will remain in the blood. Because here the free form is, sorry, no. Here it is more volume of distribution, so it will go more in the tissue. It will enter in the tissue and it will remain in the blood. It will remain in the blood. You got the point? So there are two type of drugs now. The free form will go in the tissue, right? And the bound form will remain in the blood. So the drug which is having high volume of distribution will have high free form. It will enter the tissue. And the drug which will having low volume of distribution, it will remain in the blood only. Everyone give me a thumbs up. Everyone give me a thumbs up. Now there can be poisoning of any of the drug. Poisoning. Just suppose a person committed suicide. Try to commit suicide by ingesting a drug. By ingesting a drug which is having high volume of distribution. Another person try to commit suicide by ingesting a drug which is having low volume of distribution. My question to you, dialysis will be functional for what? Which of the following? Dialysis, hemodialysis. To save the person, you will do hemodialysis. Now, in hemodialysis, you take the blood out. You don't take organs. You take the blood out of the body, filter it, so that whatever drug present in the blood is remain in the filter, and you re-inject the blood. That is the phenomenon known as dialysis or hemodialysis. We do it to save the person. to save. So dialysis किस में useful होगा? The drug having high volume of distribution or the drug having low volume of distribution? I'm asking to you. I'm asking to you. So Shivam Kumar is saying for free. No, not for free, Shivam. Free to the drug which is having more free form, it will enter in the tissue. So all the free is present inside the tissue. You are not taking tissue out. You are taking the blood out. So the drug which is having more bound form, the drug which is having more bound form, uske liye hemodialysis is useful because bound will remain in the blood. If 90 is bound, 90 will remain in the blood. Only 10 will go in the tissue. But if 10 is the bound, only 10 is remaining in the blood, 90 is entering in the tissue. So no need to take the blood out if only 10 is present. 10 को छान के क्या कर लोगे? 90 is already present in the tissue. Give me a thumbs up. Everyone give me a thumbs up. So that is the concept I want to give you here according to volume of distribution. Yes, so Abhirami is saying hemodialysis for low volume of distribution. Very good. And hemodialysis for low volume of distribution, Abhirami, and no hemodialysis for high volume of distribution. Agreed? So it is written here. So in case of poisoning, the drugs which is having high volume of distribution, don't do hemodialysis. Don't do hemodialysis. So don't do hemodialysis. Don't waste your time, money, energy, because time is precious in these cases. These are the emergency cases. Imagine there is a young boy in front of you who has committed suicide. He is unconscious. He is on the stretcher and parents are begging कि please save my child. No, you cannot save child. Let's try hemodialysis. देखते हैं क्या होता है. No, you see कौन सा drug उसने ingest किया है. First you ask the parents which drug he has ingested or taken. So they will show you the empty strip or they will tell you the name. He has ingested 100, 200 tablets of this drug to try to commit to suicide. So this is the empty strip we found in the room. So you will see the drug. Now just see for that particular drug, whatever that boy has ingested, it is high volume of distribution or low volume of distribution. If it is high volume of distribution, don't do hemodialysis. Don't waste your time. It is not useful for your case. But if the drug is having low volume of distribution, ask the parents to go for hemodialysis, take a consent and take the patient to the hemodialysis unit. So it can be useful for you. So this is the concept we got here. Everyone give me a thumbs up. You got it? So the drug having high volume of distribution is having high free form. And high free form means all the drug is already entered in the tissue. There is no drug in the blood. So no need to take blood out and filter it and inject it again. If there is no drug at all in the blood, why to take out? Drug is present in the tissue. Drug is not present in the blood. And here, low volume of distribution means it is having more bound form. So all the bound form is present in blood only. So most of the drug is present in blood. So take the blood out, do the hemodialysis and re-inject it again. So it will be useful in this scenario. I tried hard. No one will explain you these concepts. The other people will explain you only the summary. But why it is happening, you should understand it. It is a thing, you should understand it. It is not mugging up. In the end, you just mug up, but after understanding the concept, it's easy for you to learn the things. Everyone give me a thumbs up here. I tried hard. Everyone first give me a thumbs up. Let me see if I can see your chat. Give me a minute. Yeah, I can see. So yes, so I can see your chart. So Shivang, Pranali, Kuldeep, have you got it? Rishinika, everyone, Pooja, Abhirami. Yes, everyone. So very good, very good. So that is the thing. So the drugs which are extensively bound to the plasma protein, that is having high bound form, have low volume of distribution, and the drug which is sequestered to other tissue, which is entering in the tissue, will have high volume of distribution, right? The drug which is present in the blood have low volume of distribution and it's sequestered in the tissue have high volume of distribution. We got this concept. You know the summary, or should I repeat the summary? Should I repeat the summary? Drug have two forms. Listen, I'm writing the summary. Everyone write down. Free form and bound form. Free form and bound form, right? Now, the drug which is having more free form will have less bound form. And the drug which is having low free form will have high bound form. So it is always reverse. So free drug is inversely proportional to bound drug. And bound is inversely proportional to free. We already know. So if it is 90, it will be 10. If it is 10, it will be 90. This is an example. It is not always 90-10. I just take the example, right? Now in both the scenario, this is drug A having free form 90 and bound form 10. This is drug B that is having a free form 10 and bound form 90. So free form is the form which is present in tissue. It will enter in the tissue. It will not remain in the blood. And bound form is the form which is present in blood. Have you got it? Have you got it? So what is the meaning of drug A and drug B? Let's see. Let's see what is drug A. This is drug A. So you can see the summary. Drug A is mainly present in the tissue because free form is more and it is hardly present in blood. It is not present in blood. Most of it is already entered in the tissue. It is hardly present in the blood. So here it is basically present in the tissue. It is tissue sequestrated drug. The drug which is having more tissue sequestration, right? Drug B is the other way around. Drug B, here tissue is less. It is basically present in the blood. So it is a drug which is basically present in the blood because here the bound form is more. So here hemodialysis is useful. Hemodialysis is useful for this drug and not useful for this. So this is the summary we can give you. So some drugs are tissue sequestered, some drugs are blood sequestered. So drugs are of two types: tissue sequestered and blood sequestered. Some drugs love to enter the tissue, some drugs love to remain in the blood only, depending what is the proportion of their free form and bound form. So this is the summary of volume of distribution. The formula of volume of distribution you already know. It is dose given IV upon plasma concentration of the drug. It is obvious that plasma concentration, I am saying plasma concentration of the drug. So it will be bound form only because free form is not present in the plasma. So it is obvious. So everyone give me a thumbs up and let me move ahead. So that is about the concept of plasma concentration or volume of distribution. Now, as I've told you, there are two forms, free and bound. Bound form is known as PPB, plasma protein binding. The full form of PPB, please learn. Plasma protein binding. So, however, whatever proportion is binding with the plasma protein, it is known as plasma protein binding. So as I've told you, this is this form, not this. This one is known as PPB. Plasma protein binding is that proportion of drug which is bound with the protein. Now, as I've told you, you can see here. You can see, I'm sorry. You can see here, this is the free drug. This is all free drug. I'm marking with red. And it is entering with the yellow things. The yellow things are the protein. Can you see the yellow? So this is the free form. This is the free, and the yellow ones are the bound form, the yellow. So size is increasing when it is bound. So you can see free drug is combining with the plasma protein and becoming bound. So some is free, some is bound. So ultimately some is, you are giving free only. You will give free. So outside it is always free. You can see it is all free. Once it enter in the blood, some remain free only. But after entering in the blood, some will be bound. So it depends how much is free, how much is bound, drug to drug. As I have already taught you, acidic drugs bound to a protein known as albumin. A for A. Learn it. And basic drugs bound to another protein known as alpha-1 acid glycoprotein. Ye bhi A hai, so don't get confused. So acidic drugs bound to albumin and basic drugs bound with alpha-1 glycoprotein. Right. Now learn the names of acidic drugs and learn the names of basic. So these all are the drugs which bound with albumin. So these all are acidic drugs. And these are the drugs which bound to alpha-1 glycoprotein. So these all are basic drugs. Now don't learn it is not complete list. This is only the important drugs which usually will come in your practice, day-to-day practice. You will come in contact with these drugs. So this is not a complete list, but these are only important drugs you should know. So please read the list once or twice. Now barbiturates are the barbiturates, benzodiazepines. These are the two most common sleeping pills which are used for suicidal purpose. Right, because it is easily available and laymen have a mentality, if I'm taking one pill, I will sleep. If I take 100 pill, I will die. So they have this mentality. So they take these drugs to commit suicide, the one who are in depression or they want to commit suicide. So you should know barbiturates and benzodiazepines both are acidic drug. You should know it. You should know it. They are acidic drug, right? NSAIDs, all NSAIDs, aspirin, your paracetamol, your ibuprofen, all NSAIDs are acidic only. Valproic acid, phenytoin, these are anti-epileptic drugs, right? Penicillin, sulfonamide, tetracycline, these are antibiotics. Tolbutamide, warfarin is an anticoagulant drug. So you should know these are acidic drugs. Just read the names of basic. Don't learn the list. Just see it twice or thrice. It will fit in your mind. All beta, B for B. Beta blockers are basic drugs. Bupivacaine, it is a local anesthesia. Bupivacaine, lidocaine, lignocaine, these are local anesthesia. So these are also basic drugs, right? So you can see the list by yourself. I'm not reading it, but you can see the list. So some are acidic drugs, some are basic drugs. Acidic drugs bind to albumin, basic drugs bind to alpha-1 glycoprotein. You will say, ma'am, okay, we got it, but what is the use of learning it? Why? Now, whether if I'm taking an acidic drug or basic drug, after going in my body, after going in my blood, whether it is binding with albumin or alpha-1 glycoprotein, how being a doctor, it is useful for me to know. You got my point. So you will ask this, students ask this question, ma'am, I will practice, I am a doctor, I will take surgery, I will take medicine. How these things are useful to me in my day-to-day practice while I will see the patient? It is useful for you. It is useful for you. Listen, I will come by what is the utility. Now let's see the clinical utility of plasma protein binding. That is the bound form I am talking about. So bound form, it is the free form. Free is unbound. Free form is active. Active, that is, it will go to site of action and it will show mechanism of action. It will go to the liver and show metabolism, and it will show to the kidney and get excreted. So it is the free drug which is going to site of action, liver and kidney, for showing mechanism of action, metabolism and excretion. Everyone give me a thumbs up. The bound form is the inactive. It will remain as a reservoir. It is a reservoir. It is not metabolized. It is not excreted. It will not go to site of action for showing the action. I have already taught you. It is the free drug which is entering here also, here also, here also. Bound drug is not going anywhere. It will remain in blood only. It is acting as a reservoir. So this is active drug entering here, 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 and bound drug will go nowhere. We already seen this concept, right? Now we can say plasma protein binding is a temporary storage of the drug. It is a reservoir. Give me a thumbs up. It is a reservoir of the drug. It is the temporary storage of the drug. Yes or no? So how it is useful to us to know the plasma protein binding of the drug? Okay, so let me take two drugs. You know what is the onset of action and duration of action? You know the difference between them? What is the onset of action? What is duration of action? I'm asking to you. What is the onset of action? If you are taking any drug, you have some disease. Just suppose I'm having headache, severe migraine headache. I'm taking a tablet for it, a drug for it. So this is the drug I'm taking. So after taking the drug, so just suppose I'm taking the drug at 10 o'clock sharp, right? So that is the time of administration. I'm administrating. I'm taking it with water, sip of water, and it is going. So after taking the drug, it is acting on me at 11 o'clock. So 1 hour is the onset. So after taking, how much time is required to show the action? That is known as onset. That is known as time of onset. So in emergency, you cannot afford 1 hour. So in some conditions you can afford time, in some conditions you cannot afford time, right? So onset for some disease can be slow, can be fast. It depends on disease to disease, situation to situation. So that is the onset, right? After showing, now from 11 o'clock it is acting in my body, so my headache is subsided, right? For the next 5 hours, from 11 to 5 o'clock, just suppose 11 o'clock to 5 o'clock, for the next 6 hours my headache is subsided. At 5 o'clock I am having headache again. So that is the duration of action. So duration of action. So that is the duration. So it is acting in my body for 6 hours. After 6 hours, I have to take the next dose if I want the action again. Give me a thumbs up if you got the difference between onset and duration. Onset and duration. You got that point? Yes or no? Onset of action यानी क्या time? I am taking a drug. लेने के कितनी देर बाद अपना एक्शन शुरू करेगा, वो ऑनसेट है. और एक्शन कितनी देर के लिए सस्टेन्ड रहेगा, उसके बाद चला जाएगा. वी हैव टू ड्रग एवरी 6 आवर, एवरी 8 आवर, एवरी 12 आवर और एवरी 24 आवर ना. वी हैव टू रिपीट द डोज टिल द डिजीज इज क्योर्ड. यस और नो? सो कितने देर बाद डोज रिपीट करना है, दैट डिपेंड्स ऑन ड्यूरेशन ऑफ एक्शन. सम ड्रग्स आर एक्टिव ओनली फॉर 6 आवर्स, सो यू हैव टू रिपीट द डोज एवरी 6 आवर्स. सम ड्रग्स आर एक्टिव फॉर 8 आवर्स, यू हैव टू रिपीट द डोज एवरी 8 आवर्स. So that is the duration of action. But after taking the drug, after how much time you will have the action? So that is onset. Now my point is that why I am telling you this here. Both these things depend on the bound form. How much is the bound form of the drug? Okay, let me take two drugs. Drug A, drug B. Drug A having high bound form, of course low free form. And drug B having low bound form, of course having high free form, because free and bound are opposite. So let's decide the onset and duration for each of them. Okay, let me take a drug A. Listen everyone, listen, it is difficult, huh? Drug A. Drug A is having extensive plasma protein binding. What does it mean? It is having more bound form because it is extensively binding with plasma protein, and it is having less free form because if bound form is more, that is, just suppose it is 90, so obviously it will be 10 now. Total is always 100, total 100 se zyada nahi ho sakta. So you are taking such drug for headache. I am having two options. So this is the first drug I am taking for my headache. So you say what will happen? This is having more bound form, apply it here. So just I am having headache, I am taking drug A. So this drug is going inside me, I am taking. So it will get absorbed. After getting absorbed, it is having more bound form. So 90% of which is bound, only 10% is free. Example, 10%. So 10% will enter in the tissue. So only 10% will enter in the tissue, right? So if only 10% is going to the site of the action, so it will show only 10% of the action now. But 90% is remaining here only. So onset is very slow. Only 10% is going here. Give me a thumbs up. Everyone give me a thumbs up. So it is having less entry in the tissue. By tissue, I mean site of action. It is going less to the site of action because free form will go to the site of action, not bound form. Here free form is less, right? So there is less distribution of the drug. Because of less distribution, there is a delay in the response. That is onset is slow. Onset is slow. Onset is slow, right? Onset is very slow. It is only 10%. अभी तो action 10% पे ही नहीं दिखाएगा. जब next 10% will enter, तो slowly, very slowly, it will show its onset. Slow onset drug hai, right? But what about duration? What about duration? The reservoir is more. Reservoir is more. So it will constantly will give the backup. So it will active in the body for 24 hours or 48 hours. So duration is high. So onset is slow, but duration is high. Duration is high. So such drugs have slow onset but high duration. It has to be understood. It doesn't have to be mug up. I never mug up the things. So please, I will always have this diagram in my mind. So I will close my eyes and I will imagine a drug in which having bound form is more. So what will happen? Bound form is more, free form is less. Free form is less, so less will enter in the site of action. So onset will slow, but bound is more, so reservoir is more. So duration of action is high. So such drug you take for headache, but after taking the tablet for after many hours, say for after 5 hours or 6 hours, it will show its action. But once it will start showing the action, it will be active for next 24 hours, 48 hours. So duration of action is high, but onset is slow. Give me a thumbs up. Give me a thumbs up. Now see the other way around. So take drug B. Drug B. There is another drug B, having less plasma protein binding. Plasma protein binding means bound form. Bound form. So here bound form is less. Bound form is less. So obviously free form is more. Free form is more. So imagine a drug. So you are taking a drug for headache or any disease. The drug is going inside. The drug got absorbed. But here I am saying the free form is more and bound form is less. Bound form is yes. So less plasma protein binding. So what will happen? So just suppose free form is more, it is 90 now, and bound form is only 10. So 90 will enter the site of action. So all the 90 will enter together at the same instant in the site of action. So onset is very fast. Onset is very fast. As soon as you take the drug, within half an hour, it will show its action. So you take the drug within 15 minutes, half an hour. As soon as you will take it, it will go in your stomach. It is absorbed in the blood. From the blood, immediately it will enter to the site of action. Give me a thumbs up. So onset is fast, but you see the reservoir. Reservoir is only 10%. You don't have the backup. You don't have the reservoir. Reservoir is only 10%. So duration of action is very, you can say short. Duration is short. So that is the drug. So here you can see fast response. Onset is fast, but short duration of action. Give me a thumbs up. Now it can vary from disease to disease. There are some diseases in which you want slow onset. Onset slow ho chalega, but you want duration prolonged duration, right? But in some diseases, there is emergency. You cannot afford slow onset. So onset should be very fast. So in case of poisoning or any emergency, onset should be rapid, fast. Duration of action very short hoga to chalega. So you will repeat the dose. So short duration is there. So there are two types of drugs. Depending on disease to disease, you can take the decision which drug you want. But this decision of the drug depends on plasma protein binding. So in the first scenario, let me think. In the first scenario, free is less and bound is more. In the second scenario, bound is less and free is more. Give me a thumbs up if you got it. So bound decide the duration and free decide the onset. Yes or no? So here free is less, so onset is slow, and bound is more, so duration is prolonged, right? Because it is the backup now. Backup will decide the duration, for how much duration it will be sustained, and it is the free form which will show the action, so it will decide the onset. So summary is that free form decide the onset of action and bound form decide the duration of action. If you can understand the difference between them, so there is no drug in which both will be more. 50-50% can be there, but some drugs have more free, less bound. Some drugs will have more bound, less free. Give me a thumbs up. So some have fast onset but slow duration. Some have fast, more duration but less onset. You got my point. I guess you got my point. So that is the thing. So the onset and duration of action depends on the proportion of free and bound drug. Give me a thumbs up. I'm trying hard here. No one will give you such concepts. Huh? I'm really trying hard to explain you the things. Give me a thumbs up. Everyone give me a thumbs up. Everyone means everyone. So onset of action and duration of action depends. So two type of drugs are there. Onset and duration ke liye. You can see there are drugs which is having delay response but prolong the duration of action. And there are the drugs which is having fast response but less duration of action. So it depends on the bound and free form proportion. So that will decide. And hemodialysis, I have already taught you. So hemodialysis with high bound form is not effective, right? High bound form, it is not effective. Everyone give me a thumbs up. Everyone give me a thumbs up. Everyone give me a thumbs up. Okay, there are few more concepts based on it, but my link is expiring. I started late this lecture. So give me a break of just 10 minutes. Just a second. Give me a break of just 10 minutes. After 10 minutes, please everyone join back at 11 a.m. sharp. Sharp 11 a.m. Just a break of 10 minutes. At 11 a.m. sharp, you join the link Pharmacokinetics episode number 5. That I will continue. Episode number 5, pharmacokinetics. So in the next episode, first I will just distribution almost done. So first I will finish the distribution almost done. Then I will move to the metabolism, the next chapter, the third chapter. We have already covered absorption in the last lecture. We have started with distribution. In distribution, main is the proportion of free drug and bound drug that we are learning. So few more concepts based on it, the free and the bound form. We will first finish it, then we will come on metabolism, the third chapter, and the last chapter is excretion, the biggest and the most difficult to understand. So today we will complete the entire pharmacokinetics. So 3 hour more lecture is remaining, but please join the next link. So give me a minute. Okay. So please join me back. Now there are few announcements as usual before ending the lecture. So on Unacademy, we have two type of paid subscription for the newcomers. I am telling this. There is plus subscription in which you will get only Unacademy live and recorded lecture access. And Iconic along with Unacademy, we will give you prep reader access also. So better to go with Iconic if you are thinking of taking a paid subscription. Once you take the subscription, you will be eligible for all these features, all these batches, right? So whatever subscription you are taking, it's your wish. You can see the prices of various subscriptions. You can see the prices of various subscription. And if you apply the code SACHDEV10 on any of this, you will get maximum discount. Thank you very much for being with me. And please join me back just after 10 minutes. Thank you.